the US healthcare system is kind of like an inverted pyramid. It's got very little primary care and it's got reasonable amounts of like routine but complex care and then enormous amounts of really specialized care. And I'd want to flip the pyramid around. So I'd want to substantially increase the emphasis on prevention, management of people's health, and so on. Not that people shouldn't get acute, very, very acute intensive stuff when they need it, but that I want there to be less need for it.
Team, welcome back to another week of the Mops and Mo's podcast, brought to you by the Department of Government Efficiency. Is that what it's called? Doge. Brought to you by
I don't think we got a Doge sponsorship. I don't know.
Doge.
If they want to, I mean, we can talk, but
Well, if four of us would have to leave if they wanted to bring
yeah,
one more person.
we would both have to quit, and then we'd have to fire two non-existent people before we could hire a new one. Yeah.
In other fun news, for folks that were unaware, Fort Liberty, which is where I am, is now, or once again, I should say, Fort Bragg.
Fort Liberty is where you were. You're not there anymore. It does not exist.
That's where I was. Speaking of things that were, I actually looked up on Google Maps last night, and it is the Gulf of America now.
It is. That's correct.
But only for folks who access Google Maps from United States servers, which I thought was pretty funny.
So if you VPN from somewhere else,
it's not that. Somebody from somewhere else, please confirm that for me. But that's what the internet was telling me, and I thought that was funny because it's like we're living in our own make-believe bubble of bullshit. The rest of the world's like, okay, guys,
that's fun.
But yeah, we're Fort Bragg again, and
not the same Bragg though.
Not the same Bragg. So for people that didn't know, Fort Bragg was named for Braxton Bragg, the Confederate general who was not very good at.
Yeah, we should be clear. Even if you're like a fan of preserving Confederate history and stuff, General Bragg was not like a good representative of your cause. He was not good at winning wars.
Can we just pause? Hold on, pause for a second. You shouldn't be a fan of conserving Confederate history. That just is not. That's an odd move. That's an odd move.
We'll put that one aside. I mean, preserving history is one thing. Celebrating is another thing. Those are two different things. And you can have opinions, and people have all sorts of opinions on this one.
I'm just shocked that because there were, what was it, 10 installations? It was a number. It was a fair number. Yeah. And you got to ask yourself, like, guys, what were we doing? What were we doing in the first place? But anyway,
without going down a really deep rabbit hole, look at when they were renamed.
No, I know. It was the whole, yeah. So anyway, we were Fort Bragg for Braxton Bragg, and then that went away, and we were Fort Liberty for, I guess, a little bit.
Dude, do you know the story of how it became Fort Liberty?
I've heard a couple of versions. I know the one you and I have shared is that the Special Operations community and the 82nd, or I guess conventional community, could not agree on which hero to.
So you got two major commands on the same base. They have to agree. They couldn't agree on whose parakeet was cooler.
And then a Gold Star mother recommended Fort Liberty. So on the one hand, it does sound like the most like corporate marketing name of all time, but also on the other hand, you have to admit, like, okay, fair play, Gold Star mother, I can get down with that. $6 million is what I saw somewhere, is that what it cost just the military to change the name. That's not including the surrounding community of Fayetteville, for example.
I've heard the surrounding community hasn't changed the name. I heard the road signs still say Bragg.
The road signs, but Fort Bragg Federal Credit Union was Fort Liberty Federal Credit Union. Now I guess they got to change back. There's a lot of little things like that you wouldn't have realized are affected by this. So anyway, fast forward to what, like 2 days ago? Well, 2 days ago,
and we should note, like, either 24 or 48 hours before the change, I had posted about how you should change it back to Fort Bragg. I recommended Braxton Bragg's cousin, who was a Union general and became a lawyer and was elected to Congress and did all this good stuff.
Yes.
They went a different route, but with the same exact result. They chose Private First Class Roland Bragg.
Roland Bragg, who I may catch some flack for this, but I'm going to go out on a limb here and make a guess. I don't think they had any clue who that guy was. I think they just Googled, please let there be some other soldier named Bragg. Great. He was stationed there. Even better. Boom. Now he's the namesake of the largest military installation in the world. So, hey, man, good for him.
And to provide a little bit of backing to Drew's theory there, PFC Bragg's Wikipedia page did not exist until yesterday.
The early reports on it couldn't find anything out about him. I think he has a Silver Star.
Yeah, no, he did some great stuff. for
He
sure.
served, here
But
we go. I have born in Webster, Maine, served as a 786, which is a toxic gas handler in the
oh,
Army, deployed to England and left the Army in the rank of private first class. Awards include World War II Victory Medal, Silver Star, Purple Heart, Army Good Conduct Medal, European African Medal, boopity boppity boop, Combat Infantry Badge. Cool.
yeah,
So he he was a guy.
yeah,
Um, so you have some folks saying, "Told you so." Well, look what we can do. Now it's brag again. This seems a little bit like a loophole. And then you've got other folks, like I'm sure his daughter here, 72 years old, got the phone call that Fort Bragg is named after her dad. So it's kind of cool.
yeah, pretty neat.
What a time to be alive, you know?
You're back at brag,
So back to
literally.
brag. Had to take the pronouns out of my email and add the brag back into it. Who knows what next week has in store? Speaking of having things in store, who are we talking to today?
Yeah, we should kind of pivot to the episode. You didn't have a
Hard.
smooth pivot there.
That was a hard pivot.
Yeah.
Speaking of
Um,
military installations, and anyway,
yeah, got nothing to do with it. We actually have a rather high profile guest. This
that
one's a
may
pretty
have
big
been the
deal.
most educational banter we've had yet.
Potentially.
We taught some people some things.
Well, you've set up a pivot now because speaking of educational,
Mm,
our guest is a
boom.
professor.
Look at that. Can't help ourselves.
So we have joining us today Dr. David Cutler. He is an American economist who is the Otto Eckstein Professor of Applied Economics at Harvard University. If that weren't good enough, he holds a joint appointment in the economics department at Harvard Kennedy School and the Harvard School of Public Health. He is a faculty member for the Harvard Center for Population and Development Studies and serves as the commissioner on the Massachusetts Health Policy Commission. Cutler graduated from Harvard with a degree in economics, then got a Ph.D. in economics from MIT, and then returned to Harvard as faculty. He's also served in the administration of two different United States presidents. His book, Your Money or Your Life, provides an introduction to the U.S. healthcare system. Easy, small topic, no big deal.
Yeah, nothing small.
If you don't want to read the whole book, it is the topic of the New York Times Magazine article, The Quality Cure. And then we do briefly on this episode discuss Cutler's 2003 study, which is Why Have Americans Become More Obese? And he gets into the economics of our food supply, mostly coming down to processed food and mass food packaging as root causes of that phenomenon. But we discuss all that and a broad other range of how economics influences health outcomes for Americans in this episode.
And to be honest, I'm not even going to pretend to be able to grasp the depth of his research. I mean, you kind of mentioned a couple of things there. His book. What was most interesting to me about this conversation, and what I hope most folks take away from this, is that obviously healthcare, obesity, these are very sensitive topics with how the political space has been going lately. And my takeaway from talking with Professor Cutler is he has a very objective way of explaining a lot of these things. I think that he sees both sides of just about every argument. Obviously, he takes a stance on a couple of different things. You mentioned he's been involved in a couple of different administrations, but his take on healthcare was fascinating. And I think although he doesn't specifically speak, we did ask him a little bit about some opinions on the military system, but I think there's some really cool possibilities and some really cool takeaways for folks who are either working in military healthcare or who have opinions and ideas about what military healthcare could look like. This is a great conversation to pay attention to because, again, you've got a Harvard professor who specializes in health economics, basically speaking to what the research has shown over the years. And it's a fascinating conversation.
I know for me, we talk about Goodhart's Law a lot, and it was pretty cool to talk about Goodhart's Law with an actual economist because that's where Goodhart's Law came from, is
Hmm.
economics. But just a really wide-ranging conversation here. Some interesting insight into like what medical conditions we have gotten better at treating and preventing, and which ones we have sucked at treating and preventing. Yeah, just I mean, we probably don't deserve to have someone as qualified as Dr. Cutler on the podcast, so it was pretty awesome to have a chance to chat with him.
Yeah. So again, one of those episodes, I think it's worth paying a visit to the show notes to gather some of the links, some of the research, definitely the link to his book, but enjoy this one.
Your background is economics. I'll start there with a concept we talk about a lot that comes from economics. We have applied it to fitness and performance, it's Goodhart's law. I'm not sure Goodhart would totally agree with how Goodhart's law is used today because he was
Mhm.
speaking very specifically about economics and it's been broadly generalized. But for the audience, if you haven't, I mean, if you've been following Mops and Moes this long and you don't know, come on, guys. But Goodhart's law, simplified version, is that when a measure becomes the goal, it stops being a good measure. And I saw some of this pop up in your research. One classic example was medical coding is indicating that conditions are getting more and more complex and difficult, but that's not because the patients are actually getting more complex and difficult. It's because it's more profitable and clinics get reimbursed for more money when that happens. I'm curious, one, your thoughts on Goodhart's law in general, but two, just some examples of that in the healthcare space.
So I think you're right. It's an issue. It's not always an issue in the sense that there are some really, really good measures of outcomes. Like, for example, what is the mortality? If you're comparing different hospitals or different, physicians, what is the mortality rate for patients with common conditions that are not selected by the doctor to go there? And that can be a very good outcome. And obviously, it's a very meaningful outcome. So there's certain circumstances where the outcomes are good. They actually mean something. They're not manipulable, so that works well. Where you get into trouble are where the measures are either half baked, so they might mean something good, they might not always mean something good, or where they're manipulable. And measures that are manipulable are really problematic because then what you learn about is how good people are at manipulating things, not at how good they are at the underlying thing. And that's some of what's happened with medical billing, which is, in order to compensate people fairly, doctors and hospitals and everyone else fairly, we've said, well, we should pay more if the patient is sicker. And that's great. That's a great concept. But then once you say that, when you then say, okay, how am I going to measure how sick the patient is? So I'm going to measure how sick the patient is by how many diagnoses they have. So then all of a sudden you've opened yourself up to the more times that the doctor writes down a diagnosis for you, the more times the doctor is paid. And then you've got yourself into exactly that tailspin, which is therefore there's a rat race to code patients as sicker. And that takes away from some of the good rat race, if you will, which is I want to actually be better at care. Because sometimes it's easier to meet the metrics by making your patients look sicker than it is by making your outcomes be better.
One of the phrases you use in your book, granted years back, but I'm sure it still applies, performance-based healthcare. Can you explain that? Because you just sort of walked through, I guess, the negative side of where that could go. That's a very catchy phrase.
Yeah, so one of the general themes of health economics has been this sort of pay for performance angle. One of the big goals of healthcare has been sort of pay for performance. That is, pay for the things that we really want, which are good outcomes, not just the inputs, like how much did you do for the patient.
Mhm.
And so that's again like it's clearly the way to go. That is, you would far, far rather pay for performance than pay for inputs. You don't, and that's true in the military, of course, too, right? You don't care so much, does the thing do what it's supposed, what it says on paper it's going to do. It's like, is it actually effective when
Mhm.
you need it to be effective? And so in all walks of life, in healthcare, the military, education, all sorts of things that are hard to measure, you really want to say, did the thing do what you wanted it to do, as opposed to what on paper it says.
Mhm.
So, so that's great. It then, the actual implementation just becomes very difficult because, again, there's sort of, what, it's kind of in healthcare, we think about it as sort of the numerators and the denominators. What is your outcome? Can you measure that well? And then the denominator, what are your inputs and can you measure those well? And, so you got to know a lot of stuff to be able to do it right. Now, the good news is you probably don't have to be perfect, and it's better than just paying for volume to pay for value. But you do have to, but you always need to pay attention to it because you just, you don't want to be stuck in a situation where you've measured the wrong thing all the time.
Mhm.
So several things you've said lead me in different directions, and I'm going to try and like get
Mhm.
on a single narrative, hopefully here. One is you're speaking to the core of the whole framework of measures of performance versus measures of effectiveness. So hopefully the audience is picking up on that. Second, that kind of reminded me of how I ended up finding your work as I was reading a bunch of research a couple months ago. And that is, I was trying to find an answer to the question, do healthy doctors get better outcomes for their patients? Do doctors who take care of their own health take care of their patients' health better? And the stumbling block I ran into is that there's a decent amount of research on how does being healthy change a doctor's behavior? Are they more likely to counsel on certain things? Are they more comfortable with things? Basically survey answer type of research. I had a really hard time finding outcomes based assessments of how a doctor's health impacts patients' health. I'm curious if you know anything that I wasn't able to find, or is it just that hard to actually measure outcomes in this space?
I think it's probably that hard to actually measure outcomes. And I also think, we're not, because of data privacy issues, it's sort of very,
Hmm.
doctors don't want their health records being made public, and that's
Sure.
totally understandable. So when you say, well, here's a doc, for example, in the VA, and they're treating patients and so on, we can know, if you have access to VA data, you can know, how they're doing in terms of treating VA patients. But then like to match that up to the doctor's own health, that's a little bit more difficult because now you're getting into much more sensitive things where you've sort of identified an actual human being.
Hmm. I hadn't considered like the privacy hurdle. I'd considered just like the difficulty of measuring outcomes piece of it.
Mhm,
And that's a
mhm,
compelling answer to why that just wouldn't be,
mhm.
you wouldn't get an IRB approval for a study to do something like that. I can see it. I'll set up one that Drew and I often end up talking about. I think Drew is more often put in the position of like demonstrating data to like say what we're doing to commanders. I think he ends up in that seat more often than I do. But there's a classic quote. I've posted about this before, but it's what gets measured gets managed. It's often attributed to Peter Drucker, and it's often treated as though it is wisdom to be shared and encouraged. Important note: Drucker didn't say it. Drucker doesn't endorse it. It was a version of it was said
It
by
doesn't
VF.
matter.
Yeah, a version of it was said by VF Ridgway, but he was saying it as a warning. His whole point was that indiscriminate use of quantitative measures of performance reflects a lack of understanding on behalf of the person doing it and can often be worse than the problem it was trying to solve in the first place. I'm curious. Again, I'm just going to do this the same way as last time. I presented a concept. I'm curious about how you've seen it play out in your research in the healthcare world.
So it plays out quite a lot in the healthcare world. Again, both for the pluses and the minuses. So the pluses of doing it are that in healthcare, we always used to assume, well, okay, like the initial way we started off healthcare was, look, doctor knows best. So if the doctor did surgery, surgery was the right thing. And if the doctor gave a pill was the right thing, and so on. And then, as people looked more and more, they were stunned at how off the doctors were compared to what the guidelines were. And every, study, there's sort of study after study saying like, look, you know, care is not up to guideline levels, and docs are doing a ton of things that you can't quite figure out. So then we're like, okay, so why are they and so they're doing all these things like surgeries they don't need to. And then at the same time, there are a lot of things we thought they should be doing that they were not. Like for example, when a patient came in, and they would measure their blood pressure and so on, then they'd say, well, take this pill. And they would never actually follow up to see if the patient took the pill. They would just say, take this pill. And then if the patient didn't take the pill, they would just say, well, not my fault. I told the patient to take the pill. The patient didn't take the pill. That's the patient's fault. But yet we know the doctor's involvement can matter. Like if the doctor sits down and explains to the patient and, what's going on and why you need to take that pill and why it's important and what it's doing for you and all that, then the patient is more likely to take the pill. So there were all these things we were not measuring that were like super important for people's health, both the overdoing it and the underdoing it, what people call overuse and underuse in medical care. And then it became a sort of mantra to say, okay, well, we got to fix overuse and underuse, and we absolutely do. Like, if you want a reasonable healthcare system, you actually do need to fix overuse and underuse. But again, once you have those measures, if that's the only thing that you're doing, then you sort of focus on the measure. And you need to sort of refine the measure, and you need to kind of make it better and better. So I think in healthcare, people have the view that it's not a terrible thing to do, but just that like you can't just stop with saying, okay, now I've measured X, we need to, we're therefore going to improve X. Like you have to think about how that fits in with the system in which it's operating in. And okay, if X is really important, what kind of a system should I set up to make sure that it happens right?
I have to I have to ask only because we've sort of created it here. We call it the Hammond corollary because I don't know if I made it up, but we just started saying it. It's what gets measured gets managed, but not everything that needs managing is measurable. And
Yep.
the reason why we say that in our circles is because a lot of the metrics, and Alex mentioned, oftentimes I'm briefing commanders on these things. A lot of the metrics that they're most interested in are the easiest ones to capture, the PT scores, the musculoskeletal injury rates, the stuff that like you can put stoplight charts and graphs and things like that too. But what we're seeing is obviously there are other things that are much harder to measure that don't need any less managing. Mental health comes to mind, all these sorts of
Mhm,
things. And
mhm.
I'm curious, having now just listened to you riff off of what gets measured gets managed. Have you seen changes in kind of the healthcare world's perspective on that second piece of it now that we've, and maybe this is me jumping way outside of my scope, but it seems as healthcare has become more holistic, we're starting to account for more of this, the quote unquote squishy stuff.
We are definitely trying to account for much more of the squishy stuff, and we do have ways of measuring some of the squishy stuff. So we do have ways of saying, how much, what is mental health like? Okay, we actually have very good summary metrics and stuff. So that's one of the things we've learned is that, again, if you focus only on some metrics, then you'll get all the attention on those.
Mhm.
So if you think about health in terms of that way, there are multiple dimensions of health. In my work, I often use 5 or 6 or 7 or 8 different dimensions of health, from physical activity, like can I walk a mile, can I do whatever? Mental health is a big one, pain is a big one. Does health interfere with your job? Like separate from can you walk a mile, does your health interfere with your job? Does it interfere with your activities in life? So there are a bunch of things like that. And actually on most of these, there are sort of reasonably well done survey metrics that one could that we have that people can use. So it's in healthcare, we feel like the issue is not so much that it's impossible to measure a lot of the things that we want. It's hard, but we've kind of put in the legwork to know how to do that.
Hmm. So this is this is potentially zooming out a bit. We've talked about how hard it is to measure things. We've talked about what needs to be measured. We've talked about effectiveness versus just measuring activity. Um, we, as non-experts in the space, certainly not economists, have repeatedly talked about how important incentives are for producing the outcomes you want, like aligning the incentives so they encourage the outcome you're hoping for.
Yep.
And that's kind of the root of economics.
Yep.
So I'm curious. This will be kind of a two-part. Well, no, we'll keep it to one question at a time. Are the incentives in healthcare currently aligned towards producing health?
No.
Okay.
The basic answer is no.
I love that.
They're generally designed towards producing treatments. What we're trying to do is align them towards producing health, but that's sort of hard to do. So typically, what you have in healthcare now is, we went from a situation where it was 100% on producing treatments to where it's sort of 85% on producing treatments and 15% on producing health. And okay, that's good. So that's better. So people do worry about the health part, but still, like, at base, the doc still thinks of him or herself as producing treatments. And so making that switch is going to be hard. It's hard for some of the reasons that we're thinking about. Like, the minute you say the goal is to produce health, then it's like, well, okay, so if I select healthier people to treat, then am I going to get paid more and stuff? So it's easier to measure, like, did you operate, than how good was your treatment in terms of helping to cure the patient. So we've done a lot of kind of measurement of health, so we're okay on that. Again, you can influence health by both doing a better job being a doctor and by selecting healthier patients to begin with. And that's the problem that we face. Fundamentally, I would say the incentives in healthcare are in that mix between producing quantity and producing quality. And what we really want is to produce quality, and we're stuck in many circumstances measuring quantity. So that's one dimension of it, is we're still stuck in the sort of quantity over the quality dimension. And the other thing I would say, which I think is very important, and I genuinely don't know how important it would be in the military context, is in healthcare, we often think about it, or at least traditionally we've thought about it as a sort of individual level thing. Like the doctor is what, go back to the example we were talking about, the doctor recommends the hypertension treatment and the doctor does the surgery and stuff. But actually, it's much more of a team sport. So maybe the doctors should not be calling you to see, did you take the high blood pressure medication, but maybe the nurse in the office should be calling. And so maybe the metric that we should be grading is not the doctor, but the care system that the person is a part of. And some care systems can be better than others by changing who does what and how do you work together to produce something. And I think that's true in the military as well. That is, you can blame the pilot for, whatever, but like if the guy didn't load the equipment the right way, the pilot, can't do that. So it's a system problem. And that's actually creates its own set of issues in dealing with the system problem because you sort of the you've got to sort of penalize and reward the system, and then if I'm doing that, have I removed the incentive for each individual to do well and stuff? So it gets into that kind of thing.
So that gives me a chance. Actually, I do want to clarify one thing and then give you a chance to talk about something I've read from your work that's very related to your last point. One is Dr. Cutler's mentioned a couple of times doctors selecting their patients. I think for a military audience, we don't deal with this as much in like the TRICARE world of healthcare, but commonly out in the civilian world, and this is especially true for specialist care, unique conditions deep in the world of specialty medicine. Like doctors receiving referrals have a fair amount of leeway in determining whether some patient is a good candidate for their care. And if you want your outcomes to look really good, you can just specifically choose the least complicated patients that you think will have the best potential outcomes and pad your numbers that way. So it is a complicating factor because if we go too much in an outcomes only oriented approach, then doctors will only treat in situations where they know they can get good outcomes. It's not as like this isn't an either or situation. It's an how much of both situation. But what I want to set up for you is you talked about system problems and you talked about indicators in those systems that produce outcomes. And I've read a little bit of your work. I'm curious, private equity acquisition of hospitals and what happens to their quality following that. You've done work in this space. I just want to tee you up to talk about some of it.
Yep. Just to go back to your previous point, by the way, I think there are probably circumstances where it's relevant in the military too. Like, for example, if you're going to think about obstetrics, a high risk, some birthing moms are high risk and some are lower risk. And if you're going to be penalized for example, a bad outcome, independent of risk of the mom, then you're going to have some of the obstetricians saying, look, I can't handle you. You're too complicated for me.
Mm-hmm.
Which may just mean I don't want to handle you because I think my outcomes are going to be bad. So there are circumstances where that's I think that's relevant in the military as well. On the private equity thing, there's a relationship between the various things we were talking about in the following sense. What private equity is very good at is figuring out what the incentives are and then how to do stuff within those incentives. Okay, you get paid money for doing X, let's do more of X. And that's great if what you're paying for is exactly what you want. Like, I really want X done, so let me find the most efficient way to do X, and that's what a private equity firm would be very good at. And it's not very good when what you want is harder to measure, like I want a better care process. So what we found with private equity is that it'll do the things like extract value that in another business you might be fine with. Like, for example, gee, this retail store is just underperforming. We've got another four nearby. Let's, close this one and use the other four nearby, and that'll be fine, and everyone, no one will be any worse off. And it sort of takes that, and then it says, oh, okay, therefore, let's extract the money from this hospital. And oh, well, if we can't make it work, let's just close this hospital. But oftentimes when they can't make it work, that's a sign that the hospital is really valuable. It's just serving patients who aren't high income. But nonetheless, they'll close it anyways. And so it's a problem that the incentives are designed to make money, and the incentives are not the same for everybody. So ironically, the sort of people who we most need to deal with, the poorest, the sickest, the most disabled, often have the lowest income. And so often they're the least profitable. And that then makes it be, private equity is sort of really difficult in that circumstance, because it's not going to care that this person is really, really valuable to society to treat.
I'm curious, not knowing a ton about maybe how like the sausage is made on the back end of healthcare economics, but you've laid out compelling arguments for a lot of different, I guess, directions one could go in terms of maybe seeking solutions for some of these problems. In your work, is there a receptive community on kind of the healthcare side of this equation that might hear you say something like that and say, hey, maybe we shouldn't go towards private equity, maybe we should go in another direction? Like, is the healthcare system at large improving, trending in the
I
right direction, or
I
no?
believe it is improving. So relative to, a decade ago, let's say,
Hmm.
over the past decade, medical cost increases have slowed enormously, and we knew we were spending too much. Medical care quality has probably gotten a bit better. So despite all the failures, and private equity has been, a big failure in many parts, and other things have not gone anywhere near as well as we'd like. Despite all the failures, I think things are getting better. I think it's interesting because some of this is because healthcare is such a sort of um, study-driven field. That
Hmm.
is, to get a new drug approved, you have to do clinical trials. And if you want to convince other docs to do a new surgery, you've got to do clinical trials. And so, like, the basis of all practice, or much practice, is clinical trials. And so therefore, if you can present a well-done study showing that something doesn't work, people are like, well, maybe that's right. And then you can say, oh, and then I can do a study where I do a different payment system. And so there's a lot of receptivity towards thinking about, hey, look, let's treat this scientifically.
Hmm.
And that I'm not sure how much that's the sense in other, in other areas, in military. I just don't know. But the science part does help out a lot with that.
And maybe as a follow on, but also just purely out of curiosity, because I mean, well, there's really no other way to phrase it. Have you noticed that a lot of the findings that come from your research change, or might they change, when healthcare becomes socialized? And one of the reasons I ask that is because military medicine is very much a socialized structure. And I would imagine that when you take away some of those incentives and the private equity and things, is it a completely different ballgame, or do some of the same findings hold true?
Um, all systems have to. So we actually have example on socialized medical care. Most countries have some version of
Hmm.
socialized medical care.
Exactly.
Generally, it works better than the US. The reason is that you don't spend as much. And the way you don't spend as much is literally you just don't make there be as many resources available.
Yeah.
So if you go to Canada, there aren't, there are more MRI machines in Massachusetts than there are in Canada. Okay, so you just literally cannot image as many people. But then now that could be good or bad, depending on how the docs do things. So what the government in Canada does is it says, well, let's you docs work out who needs to be imaged. We're not going to say who's going to be imaged or not. We're just going to say, here's what the total capacity is, and you go do it. And it turns out the docs in Canada are pretty good at saying, okay, some of these folks are really needy, so let's get them imaged, and other these folks are not so needy, so let's not image them. So if they're good at doing that, that's great. And they can, collectively, we were talking about this sort of collectively, they can do better than this individual doc saying, well, maybe here, maybe not there, maybe here, maybe not there, and so on. If they're bad at it, then it's really bad. If either the government is bad or the medical association is bad or so on, it can be really bad.
Mhm.
But in principle, you can do well. And so in most of the countries that we think about, they actually do pretty well. The kind of, if you will, the sort of higher performing type countries tend to do really well. And they have sort of better systems than the US does, in part because they don't have that sort of huge issue about, the costs are a lot lower because they figured out how to control the costs, and then within that system you can make it work better.
Mhm.
So this kind of applies to both, like our system versus socialized, whether you're military or civilian or not.
Mhm.
You've had a lot of commentary, and this gets back to the team issue versus the doctor
Mhm.
issue.
Mhm.
It also gets to a lot of topics we end up talking about on here. You'll hear commentary in the news about like doctors don't care about lifestyle stuff; they only want to sell pills.
Mhm.
Well, your argument, and one that I frankly agree with strongly, is that the bureaucracy prevents doctors from practicing the way they would choose if there weren't all these structures forcing them into a certain version of healthcare. So I'm curious, one, how does that happen? Like how do those structures emerge that push care in a direction different than medical professionals would want to go? And then on the other side of it, do you have an idea of how doctors would practice if they were unfettered by that bureaucracy? I know that's kind of an imaginary world, but I'm wondering if you have any read on that.
It is interesting, the incentives matter, and they matter in extremely subtle ways. So they matter with respect to kind of the way I think about it as being important is like, think about, whether a doctor should operate in a particular circumstance. And no doctor, I think, very few doctors sort of sit there and say, well, I'm going to make this amount of money, but it's going to cost me this much time. And, therefore I should do a calculation as to whether it's worth it or not. Like, that's just too crass. Where the money, I think, matters is it determines kind of what the standard of care is that you then work from. Well, look, in these circumstances, the standard is we operate. Maybe sometimes we don't, but whatever. But the standard is we operate. And it just so happens that the standards of care are almost always in the direction of what brings more money. So like the standard of care is, in this circumstance you operate, whereas the standard of care is never you call the patient and see why they're not taking their meds. So there's just this sort of basicness about like what the standard of care issue. If you go to like doctors in Canada and say, well, you have nowhere near the MRIs that they have in the US, like, are you rationing care? They'll say, no, we're not rationing care. And they say, well, but then in the US, they're doing all these more MRIs. Like, what are you doing? They say, well, you stupid idiots in the US, you just image everybody who's got a brain. And like half the people who don't have a brain, we image them too. Like, why the hell do you do that? So they look and they say, look, the standard of care, that's just a crappy standard of care. And so I think that's sort of it's sort of part of the way that things work is the money it's not crass. It's like the money is just sort of baked into how it works. And then the system just revolves around that. And now if you change the money over time, the system does absolutely and will absolutely change itself. But it's not as easy as just like, oh, okay, just have the doctor make a different calculation the moment that he or she is thinking about what to do with that patient.
I the fact that you chose MRIs as the example too, I think is extremely relevant to conversations we've had on here before.
People
We've had a few
love
physical therapists
people
on
love
injury
imaging.
research.
Love
Yeah, and I
imaging.
think I think there's this idea, and I see this especially commonly among soldiers and service members, partly because they really want things on their record because it helps them get disability
Yep.
ratings later.
Yep.
But it stems from a bigger picture thing of people think that an MRI is just a picture of an injury. And if the doctor is not referring you for an MRI, it's because they don't care about you or they're a bad doctor
Mhm.
or like the system hates
Mhm.
you and is terrible.
Mhm.
And those folks aren't spending any time. And we shouldn't expect patients to do this, but if you spend even a few minutes looking at the literature, there's a ton of situations where an MRI is not indicated, would not be helpful for any kind of differential diagnosis, and in fact may worsen symptoms. And that sounds crazy, but like showing people a picture with some dark white spots on it can change their perception of their own pain and condition and limitations. And I just It's a fascinating issue because I hear it all the time, like, oh, my military doctor didn't refer me for an MRI. That's because military healthcare is bad.
Mhm.
Maybe not.
Yeah, the MRI is one of the classic, imaging is one of the classic examples of medical care. So one of the things in medical care, just to sort of put this in a broader context, is the almost all medical care can bring incredible benefits and can also do harm. The harm may be financial or the harm may be clinical or both. But and now some things are so harmful that you would never give them to the patient who doesn't need it. Like you'd never give chemotherapy to a patient who doesn't need it. Never give a, cancer, leukemia drug for a patient who doesn't have leukemia because the harms are so big. With MRIs and imaging in general, there's such a huge gray area that you can way overdo it on the imaging and not feel like you're harming the patient.
Mm.
Well, that MRI, maybe it'll say something. I don't quite know, but shouldn't we be getting it just to be sure that you're okay and so on. So there's that. Whenever you're in
Mm.
that circumstance where there's a huge gray area, you can have one country say, no, I'm not going to do it. Another country say, of course, we do it on all these patients. And like all the doctors can truly believe they're doing the best thing, even though like it can't objectively be true that they're all doing the best thing.
I want to kind of riff on like I guess patient misconceptions is how I would bundle this up. But we talked a couple of episodes ago. We were talking about, and this gets into incentives a little bit, but the whole system is sort of propped up to a sick person is a more profitable person than a healthy person. And I mean, people may disagree with that, but it's sort of objectively true. Like when we get into long-term drug prescriptions, et cetera, et cetera, if you are sick, you are more valuable to this industry than if you are healthy. And I'm curious, just based on your body of work, have you seen that play into this broader narrative about how Americans are getting sort of sicker and we're getting, I mean, obesity obviously is part of this conversation, but is there a way to move this massive behemoth towards a system that incentivizes you not being sick, or is that ship just sailed?
Yeah, sometimes being sick is more profitable. And sometimes it's not like, again, if I pay on a performance basis and I say, well, if your patients
Right.
are healthy, you get paid more, then like I really want them. What it is, but I think the spirit behind what you're saying, which is exactly right, is we don't really have a healthcare system. We have a sickness system, sickness.
Yeah, exactly.
And so it sort of likes to, it's sort of designed to take care of you when you're sick and not to prevent you from getting sick. And none of the prevention stuff pays.
Hmm.
The again, coming back, what people want to do is they want to say, well, let's change the incentives so that the incentives are to keep you healthy.
Hmm.
And when you do that, there are a million ways that, the medical system can work to make you healthy, from helping you with your eating to helping you take your medications to helping make sure your mental health is diagnosed and treated to, like there're just a bazillion things like that that the medical system can do. And so the challenge is then, to how to figure out how to turn a sickness care system into a healthcare system. We actually have some examples in other countries that do okay at that. Because sometimes when the money is limited, you can really get the docs to focus on, on how do you care for people better. And so that's, that and so like they say, well, gee, look, I'm not going to make money if you're in the hospital, so let me send the nurse out to keep you out of the hospital because like I don't have enough hospital capacity to do anything with you.
Hmm.
So that's an example of where you can do better, but it's a very different system and it's much more public. Like your standard, private medical practice is really focused on sickness. And you really have to get more into the kind of public sector before you get a lot more focus on the kind of prevention, right? There's a reason why, the CDC is public and not private. And, a lot of prevention is done publicly, not privately.
I have to ask because you sort of flew by it, but which country is doing it the best, or countries?
The sort of Northern European ones, like for example, in places like the Netherlands, they have, nurses who are in the community and you just go there. Um, there were no number of countries that had great health outcomes, even with terrible incomes. Like, for example, Cuba always had great health outcomes far above what its income would give. I mean, the country was a disaster and there's no way you'd want to have lived there, but the health system was very good because they were very good at primary and preventive care.
Hmm.
There are parts of India where that was true as well. There are parts of Scandinavia where, the local government is sort of in charge of 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 things and the governments are very competent and so they're like, okay, let's invest in community-based care. So I would say the sort of better functioning countries like that. But then you get to the sort of, think of all the countries in the world where, corruption is high and that those are also countries that don't run their medical system well.
Hmm.
So I don't want to take this in too much of a sociology direction because we've got an economist on here, but do you think part of that, and this is just from conversations I've had around this space, things I've read, some of the countries you cited also happen to be countries that are a little more homogenous, whether it be culturally, socioeconomically, ethnically. And it seems that in more homogenous societies, people are more on board with public investment in things that benefit the collective rather than the individual. Is that a big piece of this problem set?
Yes, I think it is a big piece of it, actually.
Okay.
I think that in the US, we're I used to think I've done health policy in Washington various times, and I used to think of, if you will, the sort of good headline and the bad headline, like if you were trying to, change medical care. So the good headline to see in the newspaper is poor to get same health care as rich. So that's a good headline. And the bad headline to see
Mm-hmm.
is rich to get same health care as poor. And hmm, and I think you could substitute other adjectives into that.
Yeah.
Immigrants to get same health care as natives, or natives to get same health care as immigrants, or minority groups to get same health care as majority groups and the reverse. And so there's a sense in which if we're not all we,
Hmm.
then that makes it be really hard to run a kind of health system that way. That much said, people sort of intuitively though do know that like um you it's impossible to run a healthcare system if people are not in it. Right? Like, you want to prevent disease. Well, great. If you don't have insurance, what are you going to do? So people sort of understand. So like people kind of think that, for example, even people who are here in the country illegally probably should get some medical care for things like that. But like if you then say, okay, therefore we should like cover illegal immigrants or pay for, no, God, no. So there's this kind of tension that you don't have in other countries in quite the same way.
Like I said, I don't want to turn it into a sociology discussion, so I'm kind of gonna
It's such a
like
fascinating rabbit
I,
hole, though.
I think that sits there. We might do an episode on that topic in the future, but it deserves its whole own conversation. But I'm gonna do a little bit of a hard pivot into something that seems to happen a lot. I don't want to make it like a sub segment of the podcast, but this is where I quote you to you, and then let you just kind of explain your quotes.
We need like a jingle, and like Alex quotes you to you. Do do
You
do
know,
do 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 do. Okay.
so quote number one. You'll already be familiar with these. A pretty smart guy said them. First one is the ultimate irony of healthcare is that medical treatments change greatly over time, but the structure of the medical system does not. This
Who
inertia
said
creates
that?
real problems for patients and clinicians when major change is needed.
Absolutely.
I'd love some of the context behind that quote.
It goes back to what we were talking about, which is, if you brought Marcus Welby in back, 1950s TV doctor back into healthcare today, he wouldn't recognize a single damn thing that was done, but he totally recognized the way in which it was done. And that's a bad sign because there's almost nothing in this world that's done the same now as it was in the 1950s, but you still have doctors in their office and you go to their office, they do their thing to you and so on. The only use of the fax machine that I can detect that still exists in America is in medical care.
Oh, I will riff on that one as
The military
a
loves a fax machine.
I used to be active duty. I'm currently reserve military, and that also puts me in a weird like dual status as a veteran and a reservist. I have had to fax records on numerous occasions.
You're like, why? What was the Lord doing?
I had to go downtown and find a place where I could pay to fax. Like
It's
not even like the federal building I work in had a working fax machine.
Yeah,
And
it's just absurd, right? It's kind of like what the hell happened? And yet we sort of do that, right? And so that's an example. That's just like one small example of how the medical care system has not kept up with our systems for
mm,
anything else in the world. And that's a real problem. And it's sort of nobody's fault and it's everybody's fault.
hmm.
It's the system's fault, if you will.
Yeah. Well, when it's the system's fault, it's really hard to like get anything done.
Oh, absolutely. No, absolutely. And that's why some of these things persist. Now, you then have various efforts to try and do better. And, every so often we attack it. I mean, the good news is you only have to fix it once and then it's fixed.
There's a lot of people clamoring right now listening to this saying, please, can we get rid of Microsoft Teams? I mean, the government, talk about fax machines. I mean, there's people probably still dialing up in AOL somewhere in the Pentagon. So it's not
Yeah,
just the medical system.
yeah, no, I wouldn't be surprised if that was true.
All right. Next one, and this is there's only two of these that we're doing on this episode where I
Mhm,
quote you to you, but the next
mhm.
one is the health of the US population has improved enormously in many areas, but been stagnant in others. I'd love to break that down a little bit. Where has health been improved significantly versus where have we struggled?
Yeah, and then there are actually some areas where we've gotten worse. So I
Would
can
love to hear
Okay,
those
three
too.
part. Let's go.
Okay,
Improves.
where have we gotten better? I'll give you two examples. Smoking, way down. Second example, mental health. We now recognize it more, we treat it more, it's not, just pull up your bootstraps and get going. It's not, God's fault that it's like, no, this person has an illness and we need to treat their illness. Okay, that's areas where we've gotten better. Where have we gotten worse? Obesity.
Hmm.
Obesity keeps going up. It's the consequences of that in terms of pains and joints and hearts and brains and kidneys and eyes and everything is just enormous. So that's probably the biggest example where things have gotten worse. Where things have stayed the same, um, our use of chronic care meds, like we get, if you look at people with high blood pressure, a decade ago, roughly 50 of them, 50% of them maybe were successfully treated. Today it's about 50%. People with high cholesterol, and this is not because we can't afford it. The drugs are dirt cheap. It's the system has not done much to promote the use of these. And so we're sort of stuck in this situation where we're far below where we should be.
I'll throw out for listeners if you want his position on more conditions of where we've done well and where we've lagged. The paper is where health improvement lags in recent decades. He's got some stuff on there. It is nice to hear him talk about mental health there because it sounds like his assessment of how we've addressed mental health has improved over the last 5 or so years compared to that paper. So that's optimistic. One he didn't mention, not so much improvement as you might expect on musculoskeletal pain.
And that's an example of something where there was a lot of technological regress for quite a while. But now it's actually, we've sort of like, we put people on opioids and we addicted them and we have huge deaths. Those deaths are still going up, although thankfully we're addicting fewer and fewer people from the medical sector than we used to.
Hmm.
Because doctors are much more hesitant about prescribing
Yeah,
opioids.
absolutely.
Opioid deaths are still going up, but doctors thankfully have become much more hesitant about prescribing.
So we at least blunted the rate of like it's going up, but is it going up slower than it was going
No,
up before?
no, no, it's still going up. What people are doing
Oh
is they're
God.
taking illegal opioids. So they're taking fentanyl in pills and fentanyl in
Fair.
mixed with heroin and all sorts of things like that. And so it's still spreading quite rapidly. It's like the wildfires you know, when the wildfire is still not yet controlled. And so it's still burning a lot. You can kind of see like what you would need to do, but you're like a long way from having done it.
I don't, sometimes I do this where I don't know the question I want to ask until I start talking about it. But I'm hoping from where you sit, you might be able to provide a unique perspective on this. We have talked a couple of times with a couple of different folks from different sectors about the changing nature of healthcare. The rise of things like functional medicine, like telehealth, just a different way of looking at maybe that traditional approach to doctor-patient interactions like you talked about.
Yeah.
Has
And
any of that, well, has any of that showcased itself in the data or the research?
yes, and so actually there's been quite a lot of work on telehealth, which generally is good. Like, people can use it and it seems to work out well and there are no harmful things and there's some good things and stuff like that. I want to take that farther and I want to show you, use that as an example of areas where the medical care could do much more than it does, which is think about, so unfortunately, a lot of veterans have disabilities, as
Hmm.
do a lot of the population in general, unfortunately. And we should be having a ton of remote monitoring in the house.
Yeah.
Like if someone is disabled, check how their walking is doing and are they how's their cognition doing and stuff like that. And it's not technologically hard to do that. You can put a bunch of iPads in the house. The person can put on wearables. You can wear a watch that does stuff. The phone can do stuff. And yet we don't really do that. So we don't make it easy to check in on your relative or for the doctor to monitor what's going on for someone with disabilities, severe disabilities. And, it's still, no, 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 in order to see what's going on, you've got to come to the doctor. And, that's stupid. That's really hard for that person. And if that person's living in a rural area and they need to go see a specialist 2 hours away, on earth do they do that? So telemedicine is like the tip of the spear, if you will, into what should be like, I can get, cameras all over my house and I can be notified the second any human being steps on my driveway and so on. And yet I can't get my parents' health to be monitored.
Mm.
And I mean, now they can do televisits. Okay, great. But like, I kind of want so much more than that.
So we've stumbled our way into a topic that is somewhat military specific, the like remote monitoring piece. I
Hmm.
think
Hmm.
some programs are being piloted as we speak or have been researched in the last few years in military settings that I think have a lot of promise. I think the hurdles are kind of unexpected ones. The hurdles are largely like legal and privacy related, not
Hmm.
technological capability
Yep.
related.
Yep.
But people who listen will know, and like Drew and I have multiple identities here. We're not speaking on behalf of our official roles, but we certainly
Hmm.
do have
Hmm.
other jobs.
Wearables are very
Um,
sexy these
yeah,
days.
I work with the Space Force. The Space Force is working on replacing traditional physical fitness testing with wearable monitoring.
Hmm.
And I'll tell you from working on it day to day, and I certainly can't talk about the study itself. It's still ongoing. People will get to find out in a year or two. But just the delta between what a person will tell a medical provider or a coach they're doing in terms of lifestyle habits, in terms of current fitness level, versus what a monitoring device says about it.
Hmm.
The classic, and Nate's been on this podcast a couple times. I'll probably have to drag him back on here soon. But he makes the point that if you ask a person about their health behaviors, they are going to describe an ideal week when nothing goes wrong. But
Hmm.
how often do they experience ideal weeks where nothing goes
Hmm.
wrong? Basically, never. So you like the monitoring can help you deal with the problems that are real as opposed to the patient or the customer or the athlete or whoever, whatever setting you work in, is unlikely to be as honest as you would want them to
Yep.
be.
Yep.
I've also worked around a few dietitians. I think it's even worse with dietitians. When you ask people about their nutrition habits, I don't know if they mean to lie, but they immediately start lying aggressively.
They're lying to themselves.
Yeah. So I think that's a fascinating space.
In national surveys, the average American female adult, like if you say, please record everything that you eat, eats enough to be like as thin as a pencil and no heavier than that, which just kind of can't be true.
You know, I've looked before. I've seen a couple other people in the social media world state the like average number of calories Americans consume. I've been a bit frustrated with that stat because if you chase it back to the root of where they're citing it, it comes from like a USDA report, and it's actually the per capita number of calories of food produced, which is very different than
Mhm.
consumed. We're a net
Mhm.
exporter. It's just not
Mhm.
that easy.
Mhm.
But it'd be nice to one day get to like a clear number of like average calories consumed versus average calories burned across the
Mhm.
country.
Yep.
I have a $1 million question for you. I would love to have it answered for the first time exclusively on this podcast. How do we solve obesity?
That's a really hard one. I'll tell you one thing that would help a lot. That's actually super simple. Is just tax stuff that's bad for your weight.
Well, okay, I'm glad you mentioned that because we talked about, I can't remember when, but the
So we'll reverse that future episode that's coming, still in talks with like some Colorado state people and then a nonprofit that helps with it. Because the flip side of taxing stuff that's bad is subsidizing stuff that's good.
Same thing.
And we have talked about that a little bit. And I think when we talked about it last time on the podcast, we thought we were really smart and coming up with something cool.
it's a
Um,
thing.
we're we're certainly not the only ones talking about it. And there is actually, I'm a Coloradan. I live in Colorado right now, and there is a pretty cool program in place where people on food stamps, their food stamps go twice as far if they're using them for fresh produce.
Mhm.
At a national level, it's called GUSNIP. I'm not going to
Mhm.
remember
Gus
in the
Nip?
moment what it stands for. Yeah, GUSNIP.
I feel like we could do
Um,
better than
Gus is a
that.
guy's name, and then NIP stands for like Nutrition Incentive Program or something like that. They
Mhm.
provide grants for programs that
Mhm.
subsidize healthy food for
Mhm.
various
Yep.
subpopulations.
Mhm.
So that's totally going on, and we will probably have a whole episode on that topic very soon.
Well,
You know, so
I wanted to ask about your point there because I think it was Denmark that taxed. They had like the sugar tax or the fat tax,
mhm.
whatever it was,
Mhm.
and it didn't work.
Mhm. Um, if you did it in any reasonable way, it would have to work because like people will respond to the price, right?
Yeah.
Yeah.
Soda taxes prove pretty effective.
Soda taxes do decrease consumption a lot and stuff. So if so, there's there's not like I don't know, maybe if we have, Secretary Robert F. Kennedy, maybe he'll say we ought to do that to prevent obesity. Like I would love that. I mean, if we're going to tax
Mhm.
imports,
Yeah,
if we're going to tax imports, let's go ahead and tax, stuff that kills you and drives up medical spending.
we can hope. The in present time, by the time your episode comes out, there'll be like 3 or 4 episodes between
Mhm,
now and then.
mhm,
But we just did a couple on the broader Make America Healthy Again phenomenon
mhm, mhm,
and where it gets complicated, but where there's some potential reasons for optimism on
mhm. Yep,
interventions like that that could really help.
yep, yep.
And
I do
I,
want to I do want to set up, well, not really set up. Drew asked, how do we solve obesity? Um, there's a question we have to deal with before we get to that, which is why are Americans getting more obese?
Mhm.
Conveniently, Dr. Cutler has published a paper in Journal of Economic Perspectives titled "Why Have Americans Become More Obese?" And I just want to draw out a takeaway from it that I found really valuable. And this is something we could have probably guessed at, but he did the math. Consumer prices on things like frozen foods, soda, and potato chips have increased at half the rate that prices have increased on fresh fruits and vegetables. And I just think, yes, we can blame people for the choices they make, but the structures we set up heavily influence those choices,
Mhm.
especially structures around price and price per calorie and things like that. And so if prices go up faster on things that make us healthy and slower on things that make us fat, you can't keep blaming the individual when you have
Totally for sure.
systemic factors that strong.
If you look at periodically people ask to keep food diaries. These are the same food diaries that say
Mm-hmm.
that, I don't eat anything. But if you look at like in the 1950s and 60s, when people would report eating snack, the typical snack was like a glass of milk and a slice of bread with butter. And now today, the typical snack is like a bag of Doritos and a Coke. And like the number of calories in the snack has just gone through the roof. And like, and as you said, you can't blame people. If you even in the 1950s, if you wanted the or 60s, if you wanted the equivalent of the Dorito, you baked it yourself. And that typically involved women in the kitchen hours a day cooking and cleaning and stuff like that, which is absurd waste of really valuable human potential. But the trade-off for getting women to not have to be in the kitchen the whole time is that now we have this sort of access to all this stuff, which is like incredibly tempting, but also really bad for you. And then that becomes less expensive and the norm and all of that sort of stuff. And so you wind up then being obese. So that's why I come back to like, I don't want women in the kitchen 2 and 3 hours a day cooking and cleaning, but to the extent that those things are really bad for you, then we should figure out what combination of regulation and taxation would help us out there. And, and they're just, some things we tax cigarettes, even though some people like them a lot, but they're bad for you, we tax them. So like things that are bad for you and drive up medical spending, we should just be taxing.
So I want to ask because I mean you've served as and I want to phrase this right, advisor at sort of the presidential policy level.
Mhm.
And the question about obesity, the answer seems relatively straightforward. Tax what's bad.
Mhm.
But having been where you've been and seen the way that these sort of cogs work, what do people at our level, just regular citizens, maybe misunderstand about how difficult it might actually be to do something that might seem so simple?
Yeah, so there are a couple of difficulties. One is, you know, by definition, if you're going to affect obesity, you're going to change the eating habits of a lot of people.
Hmm.
And people are not sure they want you to do that.
That's fair.
And so there's that. Um, the the I think the other thing when you come back to medical care, and people are right to feel this, people are like, I care a lot about the relationship with my doctor and so on, and I don't want you messing with that. And unlike most other industries, people are far more conservative about medical care, not conservative in the political party sense, but conservative in like, wait, before you mess with my medical care, I really want to make sure that it's going to be better and stuff like that. And that's totally, totally understandable for people to feel that. But that makes it be very hard to do something like say, well, we should do this differently because people are like, yeah, I understand you say it'll help me, but what if it hurts me?
Hmm.
And they don't trust the government. And so the default is always do nothing. And that then becomes problematic because the because you know that you know what nothing is going to give you, right? Nothing is going to give you something you don't want, but yet you can't. What are you going to do if people are afraid of it? And it's so easy, to demagogue things like, the Affordable Care Act, was, the incarnation of communism in the US, when President Obama proposed it, right? And, now, but then by the end, when President Trump in his first administration tried to get rid of it, people were like, don't you dare touch that.
Hmm.
So it was, so the whole thing, it becomes just very charged. And some of that's in a good way, like people want to be sure they understand what you're doing to healthcare. And some of that's in a bad way, like it turns out to be not that hard to oppose, not that hard to get people to oppose any healthcare reform. It's kind of easy, actually.
Hmm.
Tell me your favorite plan for the VA and give me 15 minutes and I'll produce something that probably can beat you.
Oh, we've gone there. We have talked about VA disability reform on this podcast. It is 100% a third rail. You say anything in public that indicates you might think that any veteran anywhere might have a downward adjustment in their disability cash,
Mhm.
you're never getting elected anywhere.
Yeah, 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 yeah. Yeah, so
Uh,
so it's all so it's kind of sort of absolutely that way. It's just, and there's a good part of it, which is, people like stuff and they want to feel like they're comfortable with. And
mhm.
there's a bad part, which is, they don't they're not as open to things, and it makes it far, far easier to demagogue it. And I've sort of seen that. Sometimes you've seen the movie before. You're like, I know how this is going to end. I really
It-
know. I know. I promise you, I know how it's going to end.
there's a quote about soldiers that kind of applies to all humans in general, but there are two things soldiers hate more than anything else: the way things are and change.
Yep.
And I think we're dealing with that
Yep.
phenomenon at a
Yep.
large scale here.
Mhm.
I do want to mention um, Dr. Cutler made a brief mention to if you're going to solve obesity, that means you have to change eating habits. And specifically, it means you need people consuming fewer calories per person nationally or globally. And it got me thinking. I did some rapid fire Googling, some quick back of the napkin math. Dr. Google tells me that 6% of American adults are now on GLP-1 medications. Dr. Google tells me that there are 262 adult Americans. Real fast math, 15 million people, that means, on GLP-1 drugs. We've seen studies showing anywhere between like 10, maybe even 20% body weight loss. That means a more than 10 to 20% reduction in calories consumed. That's not that much when you talk about an individual person, but it's a massive amount when you talk about how much food is getting sold, especially when these reductions are primarily aimed at specific companies producing large volumes of highly processed food. The economic ramifications of that are really significant. So we talk about this in terms of health and obesity and fitness and weight loss and nutrition, but the most powerful forces driving decisions in this space are not nutrition and health and fitness, they're economics and business. And
Those
that's
things matter a lot. And,
a lot of money.
it's a lot of money. And, I don't know if you remember, we've had periodic debates about what counts as, appropriate for school lunches.
Yeah.
Is ketchup a vegetable?
Is
And
pizza a vegetable? Yeah.
is pizza a vegetable? And all this sort of stuff. And you're right, because that's a lot of money. And so, people are willing to spend a ton of money on it. I'm actually assuming the drugs work, there's no reason why we should restrict them. We should just negotiate a low price and get them to people like we do cholesterol lowering drugs and blood pressure lowering drugs and mental health drugs and so on. And they're very expensive now, so they're not going to spend, $100 billion, on the company, but we should just negotiate a lower price and give it to people. There's a lot of sense, oh no, obesity is your fault, and therefore you should, we shouldn't pay for it for you. But truth be told, hypertension is sort of your fault too.
Yeah.
And,
Great point.
And high cholesterol is sort of your fault too. And like, we don't say, well, no, we're not going to pay for your blood pressure medication. We're not going to pay for your stroke because it was your fault. So like, let's get real about this here. I mean, if something's valuable for people, we should find a way to pay the correct price and then buy it.
That was such a touche argument. I hadn't even thought about that.
That's the classic argument.
Well played.
We treat all the downstream symptoms of obesity, but we refuse to treat the root cause because it's caught up in identity stuff. And if we stopped paying for people's drugs for any condition that they could manage through lifestyle modification, we would stop paying for most drugs.
Yeah. So, but again, that's not what people want, right? They want to be healthy. And so,
Yep.
Before we let you go, there's a question we often like to ask our experts. You fit squarely in that category, so thank you. The keys to the castle question, and it goes thusly. If you woke up tomorrow and they told you to reinvent the American healthcare system, blank canvas, unlimited money, what would it look like to you?
Think a little bit about a pyramid, if you will. So a good healthcare system has a very, very broad base of kind of preventive care, chronic care, access to doctors for immunizations, meds, preventive meds when you need them. And then above that is a layer of somewhat more specialized, but, things like, you need an obstetrician to deliver births, and you need, surgeons to do stuff and so on. And then a super specialized, kind of very high upper tier, super specialized stuff. The US healthcare system is kind of like an inverted pyramid. It's got very little primary care, and it's got reasonable amounts of like routine but complex care, and then enormous amounts of really specialized care. And I'd want to flip the pyramid around. So I'd want to substantially increase the emphasis on prevention, management of people's health, and so on. Not that people shouldn't get acute, very, very acute intensive stuff when they need it, but that I want there to be less need for it. And therefore and therefore just need fewer people doing that.
Well, I think that is probably going to end up as the pull quote for the beginning of the episode. And on that note, thank you for joining us. This has been fantastic. I spent a bunch of time reading your research, and there's no reason I should have gotten this much of your time to ask you questions about it.
Well, thank you. And thanks to all the current and former members of the military for everything that you did and continue to do. So I, as a non-military person, I really appreciate it.
Team, welcome to the back half of, well, the back third of the podcast episode here with friend of the show, Alex. Alex, welcome.
I come on once in a while.
Every once in a while. Maybe in terms of intellect, one of the highest intellects.
Yeah, I was looking some stuff up about him recently. Obviously, you can tell from the episode I've read a decent amount of his stuff. But he's been mentioned as like top 30 most influential people in healthcare, like ever.
Which, as an economist, is pretty cool.
Yeah, it's pretty neat. My big takeaway here is that this kind of tees up an episode I want to do in the future. I have a guest in mind about the difference between pathogenesis and salutogenesis. Drew, I'm not sure if I've talked about this with you. I think I've shared a little bit of it.
You're going to need to explain those terms to people who don't know Greek.
So pathogenesis is the process of how disease happens. And our whole medical system is built on understanding how disease happens so we can intervene and stop it. Versus, and Dr. Cutler alluded to this several times during our conversation, salutogenesis is the process of how health happens. And we never really talk about the factors that drive health happening. We assume it's like a light versus darkness situation, right? We see disease happening, so we have to fight it rather than separately making health happen. This kind of gets back to like the whole food is medicine conversation. Like, I don't know if we want to medicalize food because that's complicated, but food is part of how health happens for sure. And if health is the opposite of disease and all we care about is disease, then maybe food is medicine. But we always focus on the disease part. We never focus on the health part. And as I mentioned in the episode, it's a lot easier to find research on how hospitals operate and pharmaceutical mechanisms of action. It's a lot harder to find research on actual health outcomes from those things. And yes, it's because it's harder to measure, but it's also because we don't seem to just talk about it that way very much.
Well, like, I mean, we've beat this dead horse quite a bit, but it is a mops and mo's thing. Mm-hmm. Like, and he alluded to it here.
He came right out the gate talking about measuring effectiveness. It was awesome.
Right. But I'm trying to intentionally think about this through the lens of like military human performance, military medicine. You can brief so easily. Patient sick, gave patient pill, patient better, sick, health, boom. Like that traditional model that he talked about, the doctor from the 1950s coming back, immediately recognizing how we do things. I just don't know how you change the trajectory of a system that is not designed to incentivize health. And that was kind of at least my perspective on our conversation with him as an economist. Mm-hmm. It's all about incentives. It's all about, how are you going to drive behaviors through incentives? You're incentivized in this system not to be healthy. You are incentivized to be sick, stay sick, be obese, stay obese, et cetera. So that's where my head is sort of hanging out right now after talking to him is like, man, I don't know how you incentivize health, because it seems like, I could be wrong here. It seems like the way we think is if I'm sick, if I'm ill, if whatever, I will go to a specialist. However, to be healthy, it's something I have to do on my own. Mm-hmm. Like, and that's where
that's a great point.
That's where Instagram proliferates, and you get all this bullshit about like, what am I supposed to eat? Well, maybe I'll read that book or this book. And we talked about this with Make America Healthy Again, but it's like we entrust our sickness and our downfall to experts. We will outsource it. But anything related to improvement across any of those lifestyle metrics, it's very much like, oh no, that's on you. Like DIY that shit, because the doctors are dealing with people who are sick.
What was running through my head before you started talking, you kind of did the individual person level version of it. And I'm going to do my best to draw it out to like a societal level version of it. People are only really motivated to take drastic action and change things when they're at like a breaking point or a crisis.
Yeah, for sure.
So if you think you're like going to have long-term health consequences or death, you'll do the thing. You'll go to the expert. You'll pay the money. You don't really ask questions. I think if you look at the news today, we're getting kind of a master class in how do you convince people something's at a breaking point so you can mobilize them to change things. And I think gotta use that power for good and not just evil, right? Like, how do you convince people that the way the system is now is doing all this harm. And I think going back to our Maha episodes, I think that is starting to happen. I think we are starting to get people believing that the system's at a breaking point. The health outcomes, not the disease outcomes, but the health outcomes are unacceptable that we're getting. And it's time to really change things and actually invest in the things that produce health. We just have to make it less partisan and divisive and get people on the same page. Because I think at the end of the day, everybody wants to be healthy. We've convinced people that we have to take sides on this battle, but I don't think we really do.
Well, it's also, I mean, man, we could turn this into its own episode, but like to maybe bring it back to embedded military human performance, like it's an empowerment thing. I think that people, i.e., soldiers, sailors, airmen, a lot of them may not think that they have the requisite tools to do the thing, to achieve the goal, to like self-motivate, to do the training or whatever. And that to me is what embedded human performance is all about, is educating service members to feel as though they are empowered to make the change. They can do the thing. I mean, you're talking about waiting till the last minute. You don't see that just in healthcare. I mean, you see that in plumbing. You see that in air conditioning. You see, like, I have no clue the health of the pipes in my house, but if like my toilet's backed up, I'm like my whole day stops, and now I got to solve that problem. And it's the same thing with a heart attack. It's the same thing with like, your windshield breaks. Like so many things you don't monitor. Nobody really monitors systems until something is totally broken, and then it's like, oh shit, what do I do? Anyway, I'm like totally derailing myself from the original.
There's a whole episode there, because the same thing applies to like, why do we care so much about the physical domain of health and wellness?
Yeah,
it's because it's where you see the problems, even if the underlying root causes had something to do with nutrition or sleep or spirituality or social connection.
I think that's why spirituality is going to be sort of the last frontier, the final frontier of human performance, because it's the least visible.
We were just talking about this morning at work. Yeah.
Dude, we are dangerously close to a rabbit hole. Here, we're going to close this one unless you have any other final thoughts.
No, I think we've just discovered a whole episode we should do, though.
Yeah, we will. We're going to take that into the workshop. We'll come back with a full episode, but until then, stay tuned, and we'll see you next week.